So we are very, very fortunate to have Dr. Donald Berwick, who is leading us off. He is the President Emeritus and a Senior Fellow at the Institute for Healthcare Improvement. He himself was a leader of CMS. He served as CMS administrator in the Obama administration. He is a pediatrician by background and has served as a professor of pediatrics and healthcare policy at Harvard Medical School and its affiliated teaching hospital. I cannot encourage you strongly enough to read what comes out of Dr. Berwick's amazing pen. He is the author of too many publications to count, but recently he's been a very insightful voice as we cope with the pandemic and other challenges in the healthcare system. Don, thank you so much for joining us today, and we look forward to your remarks.
Thank you so much, Deb and Dr. Ted and Francis and the whole team. I really appreciate this chance to join you. Let me just check on my audio. Can you hear me well enough?
Yes.
Great. I should issue a bit of a disclaimer at the start. As I told Dr. Shortlift before I accepted this position on your panel, that I'm really not an expert in this field at all. I have some rather bigger picture framing ideas that I will try to share with you, but we'll hasten as fast as we can to get to Jay Crossan, who really knows this field a lot better and has a lot more specifics to offer. But I'm going to be at a pretty high level here in terms of overall framing. So what I want to do is work down toward the question of purpose, which is what I want to focus on with you a bit to give a stronger sense of what I think is at stake in this committee and in this conversation. Whenever I'm asked to speak about or opine on a topic related to healthcare reform nowadays, this is my operating framework. I think whenever we're considering changes in the regulatory scheme or the delivery system, or the financing system, there are always four questions to ask to judge the quality of what's being proposed. Here are the four questions I have. Will this move the United States toward universal coverage? Is whatever we're talking about going to get us closer to healthcare as a human right? We're 30 million people behind in coverage and another 50 or 60 million with inadequate coverage. Second is, what will happen to quality of care? We have tremendous a legacy of research on defects in quality in American healthcare. They include all the problems that were cited in the National Academy of Medicine or Institute of Medicine reports back in 1990, 2001, crossing the quality chasm into areas human problems of patient safety, problems of effectiveness of care, using science to guide care, problems of patient-centeredness, timeliness, efficiency, and equity of care, especially nowadays, racial equity. The third is, will this move us toward causes? That is, we're spending all of our money in American healthcare on repair shops, on treating the consequences of illness instead of upstream on causes, especially social determinants, which often, usually, almost always lie outside the healthcare delivery system itself. And finally, with this reduced per capita cost, we are at almost 50% more than any other nation on earth, certainly 30% more than the most expensive number two. And that is extremely costly to this country. The way in which we spend money on healthcare is harmful to so much else that this country needs to do, both in public sector investment and private sector investment. So whether we're talking about discarding drugs in vials or changing a payment system or proposing a new regulation, this is how I would have us interrogate it. And of course, now any group like yours that is considering this has two contextual factors that they just have to be woven into this. Otherwise, we're tone deaf. One is the current pandemic and how all of that echoes in this pandemic and future threats. And then also the George Floyd murder, structural racism, and the new surge of awareness about inequity in this country. Now, this may seem a long cry from a question about discarded drugs, but I think your job as a committee, as mine would be if I were on it, is to draw these connections, keep these connections in mind as much as you possibly can. The echoes of this interrogation in the drug disposal world clearly have to do with quality and cost. That's really the balance you're trying to speak to, because a lot of the conversations you're undoubtedly having have to do with safety issues and the promises we make to patients that they'll get exactly the medicines and the procedures that'll help them, and none that don't, and that we will not subject them to additional hazards in the care system. And then on the cost side, as Jay Crossan will undoubtedly share with us, there are really big implications here about the contributions of the topic you're addressing to excessive costs in the country. And I'm going to be speaking mainly to those two matters. The only two slides I have to share with you here have to do with what I'll call perspectives. This is background that I would put on the table if I were on your committee. The first is healthcare costs in America are much, much too high. We are not getting value at the level of expenditure we have. We rank 40th or so in infant mortality and life expectancy, and despite this extraordinarily big investment we're making in healthcare in this country, and it is confiscation. It's taking resources from things that we really have to spend money on in order to have the just and compassionate society we want. Because of the healthcare problem, schools suffer, roads suffer, workers suffer, corporate competitiveness suffers, investments in equity suffer. We are not entitled to this money. And anybody that has a question before them at the level of the National Academies, I think, has to bear a burden here, has to understand that there's no free pass here, that we've got to tackle this problem as a nation. This is contextualized further by evidence we have about the level of ways in which we waste money in the country. I wrote a paper in 2012 in JAMA which categorized forms of wastage in American healthcare expenditure in 6 pots: overuse of things that don't help anybody at all, procedures, tests, drugs, hospital days, technologies. The second are failure, drop balls, failures in coordination, when we pay a price because we don't act as a team. This leads to redundancies, to missed opportunities, to deterioration of chronic illness, and so on, all of which raise costs. The third was unwarranted variation, especially variation that adds to the risks to patients, where we don't execute care properly according to good standards. It adds cost and harms people. The fourth is administrative costs, which amount probably to $300 billion a year right now in our system because of the complexity of the payment and coding systems. The fifth is pricing. Our pricing is nonsensical. It has very little relationship to the actual cost of production. There are confiscatory profits made on many of the pricing maneuvers that occur because we let them occur. The sixth category is fraud. Now, your work has some intersections with this list of ways, but the biggest one is pricing, which is a lot of the stuff that you're dealing with in this committee, in my opinion, has to do with the doors that are wide open for pricing games. And I'm no expert in this. Jay, I think, may be able to speak a little more to this, but the problem that we face with discarded drugs, I strongly suspect, trace back to the way we price drugs. And I know that's on the table for you, and I think it's something to really deal with. Now the next point here is the key, which is, even though these forms of waste and their effect on total healthcare expenditures are extremely onerous in this country. I mean, I did run CMS in the first couple of years of the Obama administration. Therefore, I was part of the process generating the president's budget. I cannot tell you the number of times when everyone pointed at healthcare as the opportunity thief by spending so much on healthcare. We couldn't spend money where absolutely the public interest required it. And so you'd think, with the interests of the average citizen or taxpayer at stake, with the interest of business at stake, the interest of labor at stake, the interest of state governments at stake, the interest of government agencies other than healthcare agencies at stake, that there would be this extraordinarily strong political support for stopping the waste. And that's not the case. That's not the case. The will in the nation to actually tackle the costs of healthcare has been deficient and remains deficient. And the politics of this are the politics of fragmentation. Every single separate interest group stands up for its expenditures. And every separate proposal to reduce costs meets strong opposition on whatever grounds it needs. And the battles are lost. Every battle is lost. In trying to administer responsibly a public agency responsible for 110 million, the costs of care of 110 million people, CMS, my day was full with people from the public coming into my office telling me why they need more. No one ever comes in to say they need less. No one ever comes in and says, I will help with this confiscation problem of healthcare costs in America. So when you have this conversation with respect to discarded drugs and trace it back to problems of pricing or waste, and trace that back to problems of over expenditure in America, you're simply another battleground, another place where this problem of American healthcare costs is played out. And the predictions would be you'll lose. The public will lose. There'll be no progress on this level, on this particular form of expenditure. The problem is we're having, in my opinion, the wrong conversations. We're not. The right conversation would be every single party in the American healthcare system has a duty to reduce the total cost of American healthcare. It's a duty, subject to constraints, including the constraints of excellence, safety, equity, universality. All of those are constraints on the problem, but the problem has to be solved. And I guess that's too high a framing for to be useful to you. I'm not sure if we're screen sharing here, or if am I sharing my screen, or staff showing the slides that I sent?
I think you're controlling them, Don.
So you should now see the screen, which is the report from my 2012 paper on categories of overuse, categories of waste.
We see that.
You do see that. This is the 34% median figure on total expenditure in American healthcare. And you notice that excessive pricing is a big deal here. Now, Will Schrank, now at Humana, did a repeat of the exact same studies and same methodologies last year in JAMA with some slight modifications. Will's estimate of waste levels is the median is 25%, but he is the first to admit that he did not cover all the categories that my colleagues at Rand Corporation and I did in this paper. So the argument about non-value added expenditures in American healthcare, it's not, you really would have to have pretty convincing argument with data I don't know to combat the information we have about the levels of expenditure. Now, a couple of other constraints or comments on the work that you're undertaking here. I think the dynamics of failure to reduce American healthcare costs through reduction of waste are primarily political, because any form of waste is someone's income. And so there'll be a conversation, but no one will say, don't save this money because I want the money. That's not how it goes. It goes, there's an argument behind every form of waste. Now here, there is no question in my mind about the fact that what you're dealing with is waste in a very pure form. You're taking drugs, which are high priced, and throwing them away. It's got to be wrong. There's got to be a different way to do that. But the pushback will come not in a vocabulary of "I want the money." It'll come back in some vocabulary that'll be it'll try to be a trump card, try to end the conversation. The trump card in this conversation for me at CMS was safety. We had a big problem with drug wastage in the use of intraocular injectable medications, Lucentis. It was I don't know the total number, but I bet it approached $1 billion waste affecting Medicare and Medicaid both. But the conversation really couldn't be opened because the minute someone said patient safety is at risk, all other options left the table. And I would counsel you to be very, very surveillant for that kind of trumping. Safety is absolutely crucial. And any new design around the problem you're addressing has got to be very serious about taking patient safety seriously. On the other hand, all public policy searches are searches of multiple dimensions. And the two on the table right now are treating patients properly and saving money. And it seems to me that's the vector that you need to adopt as a committee to solve both at the same time. And that's really my final point, and I'll stop talking. It's that, to me, the proper sequence, and this comes from my work on quality improvement for now 30 or 35 years, is the following. The sequence is set the aims and then design around the aims. The constraint is not the status quo. The constraint is not a single aim. It's the vector of aims which are on the table. And then the question becomes not, can we do it? The question is, how can we do it? So my approach, not having the burden of serving on the committee and having to actually figure this out, is set the aims, which should be contribute to the reduction of total cost in American healthcare and preserve patient safety completely. Establish that goal, and then ask the question, what is the redesign that allows that goal to be established? Not, can we achieve this? We must achieve it. I think I'll stop there. Pretty high level stuff. I hope it was at least provocative, if not helpful. And now, as you hear Jay Cross, and you hear somebody who really knows what he's talking about.